Thank you, Andy. So thank you, everyone, for coming, and thank you for the organisers for inviting me. Yes, so I'm not an analyst, so I'm one of the exceptions in the room, I guess. And my role here is to present a data opportunity to you all, which I hope you'll be enthused about. So just a quick nod to the fact that all I'm about to say is the result of a lot of hard work by a lot of people across a lot of organisations. I can't claim it all as my own. And the most important thing I'm going to say throughout the whole keynote is that the longitudinal studies in this country are the stars of this show. So I don't know how many of you are aware of this, but the UK's got almost a globally unique tradition of running this type of research study. And before I go any further, actually, not that I can actually see, but I'd like you all to put a show of hands for those who've used longitudinal studies in their research, just to get a gauge of the audience. So roughly, even though I'm a bit blinded, I'd say maybe a third of you have. So that's great because I can remind you about a new way of doing this. But then for those who haven't, hopefully illustrate what the benefits of doing so might bring to your research program. And for those who are less familiar about longitudinal studies, I'll start with a brief definition. I put 3 criteria up on the screen, which I think are essential criteria for a longitudinal population study. Firstly, that participants in these studies are selected from the population, not from a clinical setting, really, but from the population by a set of shared characteristics. These participants are then followed up and observed repeatedly over time, and that gives the longitudinal dimension to what we're talking about. And critically, the participants are volunteers, and they take part with their study in a consented relationship. And that trust which builds between a participant and their study over time, including in many examples over whole lifetimes, is absolutely crucial, the secret sauce, as it were, to longitudinal research. So everything we're about to talk about has to be said in relation to that trust relationship, and that at the forefront of our minds. And that responsibility extends to everyone touching this data, because the data only exists with the trusted participants. So I'm going to talk a bit, just to give some flavour to this, about a few example studies. So the first off, at the top of the screen, the logo of the 1946 birth cohort. So everyone born in a secret week of 1946 was eligible to take part, and those participants have been followed up ever since. So a wonderful 80 years almost of continuous follow-up of the same group of individuals. Children of the 90s, or ALSPAC, is a city-based cohort in Bristol. That's where I worked for many, many years. Wonderful, uniquely rich and detailed. By age 18, the participants have been followed up over 120 different assessments. Born in Bradford, a city-based cohort in Bradford, deeply embedded within the Bradford Learning Health System population health management structure. So basing a cohort at the heart of NHS local policy making. Understanding society is a bit different. In this case, it's properties which are selected, and those who live in those properties are eligible. And it's used extensively across particularly socio-economic policy making in government. ELSA, which is the English longitudinal study of ageing, and NICOLA, which is its Northern Ireland counterpart, are examples of a global network of cohorts looking at ageing, healthy ageing and outcomes, which share the same protocol and questionnaires. So you can do international comparisons as to different outcomes and the way different interventions and policies shape those outcomes. Airwave, finally, on this list is an occupational cohort. So the Airwave are drawn from police forces, but there are also cohorts of NHS workers, military veterans, and those who are in particularly hazardous industries, such as people working with asbestos and other particular exposures. And in total, there's probably somewhere between 100 and 200 of these longitudinal studies in the UK, and over 5 million UK residents. In fact, you probably heard Our Future Health is just starting up, and that's got the ambition to recruit 5 million participants alone. So this is a not insubstantial population group. And there is just unparalleled depth and diversity of data within these studies, far more depth and diversity than I can hope to do justice for over the next few minutes. And the studies are collecting data through surveys. through assessment visits, where home visits, or asking studies to come into clinical settings for more detailed images, or the collection of biosamples, which are then assayed into different outcomes, including genetics. Very rich, very diverse data. And I thought I'd choose a topical example, so I look back across the Sunday supplements over the last couple of weeks, and this story stood out from the 1946 birth cohort. And they've got provisional evidence coming through which contributes to the growing body of evidence that diet plays a role in healthy cognition in later life and the risk of dementia and Alzheimer's. And what this particular study has done is it's looked at early dietary assessment up to midlife and looked at the association between those and later cognitive status in older age, and found that this early diet has a substantial association with these cognitive outcomes. And what I would like to draw on from this example is just this sense of longitudinal nature of the data and the substantial investment both from the funders and the academic community, but also the participants in providing these data over time. So this, if you look at documentation relating to cohorts, is a standard matrix of assessments down the left and then time points across the top. And you can see the data started to be collected on diet at age 4 in 1950, and then continually at different times, well, not continually, but at cross sections right through to age 70 in 2015. And it's this long-term investment which enables the sorts of research which I've just illustrated. The other thing that many longitudinal studies have sought to do over time is to enhance their data collections through linking to participants' routine records, whether it's their health record maintained by the NHS, socioeconomic records by the Department for Education, for example, or tax or employment records, also to data about the places in which people live, and increasingly about smart data, such as mobile app use or information from sensors and wearables or supermarket loyalty cards or social media feeds. So a really diverse, rich set of ancillary data which can be brought in to enhance the data collected directly from participants. And this isn't new at all. I'm sure most of you are really familiar with this example, Dolan Hill, who used the British doctors cohort in the mid-1950s, linked to mortality records in order to identify the association between smoking and lung cancer. So a well-established use of the way data are used. And it gives incredible benefits. So one of those is to bring objectively recorded data into the study setting, as Dolan Hill did. But it's also a way that studies can look at their sample and their eligible population and look at issues of bias and representation and generalizability. And then, where there's been attrition from a study, which inevitably happens, to inform statistical approaches to deal with that missing data. But it's a bidirectional relationship as well, where the study data, the self-reported participant data, can form a sort of ground truth by which you can look at coverage, quality, completeness in the routine records and provide a perspective on whole population databases and data analysis. Now, we've moved on a long way since Dolan Hill's project, where they recruited a couple of research nurses to manage their records, which lived probably in a filing cabinet in the corner of the office. And increasingly, rightly, regulators, data owners such as the NHS, and most importantly, the public, are demanding more stringent safeguards around the ever-increasing use of their sensitive data in the research process and within NHS settings. So we're moving post the Goldacre review and the Data Saves Lives policy and building on lots and lots of good practice over the last decade or so towards the concept that data analysis will increasingly happen by default within trusted research environments, or, as the NHS are calling them, secure data environments. And here the analysis takes place within the protective wrapper of technology, a secure server, where the data is held and curated and analysed, but also a governance framework, and increasingly adopting the 5 SAFEs principles, where people using the data must be trained, accredited, and vetted and suitable to be conducting research, that the project must be assessed to determine whether it's going to result in public goods and benefits, that the data are safe in the sense that they're de-identified and reduce the risk of any breach of confidentiality, that the setting protects the data and only allows this authorized safe research to take place, and only information leaving the safe outputs are that the only findings at a population truly anonymous level can leave those safe settings. Now, this direction of travel has been underway for a while and is in my opinion, the right direction of travel, and one which is increasingly going to become the default. However, it's got a burden on these 100+ longitudinal studies, where to maintain a trusted research environment has got a direct high cost and a skill set with demanding expertise in computing infrastructure, governance, legal bases, and so on, which most studies can't uphold. So it's introducing a barrier to these studies enabling a record linkage strategy, which is why, as a community, we've recognized that a new way of working is needed to facilitate this. And that this new way of working, as represented by UK Longitudinal Linkage Collaboration, or UKLLC, it was accelerated in the COVID pandemic, where in order for the longitudinal community to be responsive to the new needs raised by the pandemic and to contribute to policy making during that time, we need to rapidly come together as a community and build a trusted research environment specifically for longitudinal research, where data linkage was provided as a service, a trusted research environment, and a data access mechanism for analysts such as yourselves was laid out in an efficient way with centralized data pipelines and governance frameworks. And this is highly efficient to you as analysts because you can apply to one organization to access a wealth of data, highly efficient to the funders because it removes duplication of effort, and also reduces a burden on the data owners such as the NHS because they can deal with one organization rather than many organizations. It also introduces new scientific potential. So by co-locating all these wonderfully rich study data with their distinct populations and samples, we can increase statistical power, but also ensure the research benefits are more equitable. So the research is more inclusive of hard-to-reach communities and at the scale and statistical power needed to make it viable both for subgroup analysis and also to consider rare exposures and outcomes. But going back to this notion of participant trust, that this change couldn't be assumed to be the right thing to do, and it couldn't be done without considering what were the fundamental aspects of which drove the trust between the participant and their study. So our model in UKLLC is, while we're providing that centralized service, we're also providing an improved safeguard through the security of data analysis happening in one place rather than being distributed across researchers' infrastructure. We maintain that all the assurances studies have made to their participants are upheld, that data are only linked and shared with specific people for specific projects subject to study agreements, and basically that custodian role of the study is upheld. All participant objections are fully respected. We implement a 5SAFE framework, and we embed members of the public and participants into the decision-making process as to which projects are authorized, and also into the design of our policies and procedures. And going back to our onset, so this is now up and running. Within 6 months of being commissioned as part of the National Core Study led by Nish Chaturvedi, we developed a collaboration of 24 partner studies, many of the UK's most innovative and exciting cohorts, and a sum total of 300,000 participants. The Trusted Research Environment, the TRE, was set up using SERP technology, which is developed by University of Swansea, but also powers the Sale Data Bank in Wales, which you might be familiar with. And we've set up our data linkage processes and got all the accreditation necessary for this sort of environment. And it's allowed us to put together this unique, globally unique probably, data offer for you, the research community. So I can't hope to do justice in the top left to all the data which has been collected by these studies. And in fact, I was really taken by Peter's quote earlier from Thomas Telford, where it says, "I am not contented unless I can reason on every particular." Well, if that struck a chord with you guys, and you're the sort of analyst who is thinking, I want to understand more about what I'm seeing in my results, you might find the data you need in one of those study data sets, because they've got unique data which isn't present in the routine record. We've systematically linked NHS England data and Welsh data, and a similar application is under review in Scotland. We're totally committed to four-nation follow-up because that's where our participants of the partner studies are distributed, and we're waiting for legislation to come on stream in Northern Ireland to set up similar. We're also an interdisciplinary response. So we've got ministerial agreement to link to HMRC and DWP records, and looking to link to other socioeconomic records after that, such as education. We're geocoding participant address data and linking information about people's environmental exposures, the property in which they live, and their neighbourhoods. And I'm not going to dwell on this, but basically the key message here is if it's a centralised NHS data set as managed by NHS England or Public Health Scotland or one of the other organisations, we can link to it. So we're talking about secondary care data, community mental health care data, cancer mortality register, dispensing of medications, obviously the COVID data set because we've still got an active COVID research program. And I will say there's a little bit of an Achilles heel in our model at the moment. Fortunately, we're able to link to the COVID GP data set in England, but we're still in discussions about how we can expand that to the full GP record for our consented participants. I mentioned the socioeconomic records, and these are increasingly important as some of the most pressing policy questions, looking at the relationship between health outcomes and productivity and employment. And we're linking now, with the support of Administrative Data Research UK and the Office for National Statistics, to employment, earnings, pensions, benefits, data from HRC and DWP. And then we will move on to other sources there. We've modelled air pollution data at a very fine both spatial resolution but also temporal resolution to look at critical development windows such as trimesters of pregnancy and whether exposure to air pollution or noise in these developmental windows are then associated with later outcomes. Looking at green space, walkability, and basically any information which can be linked to a property via UPRN, which is a unique ID every property in the UK's got, or postcode or neighbourhood indicator, we can then link into this environment, subject to full transparency with our participants and studies. Just going to give a couple of very brief examples of the way this resource has been used by analysts during the COVID programme. So the first example is about long COVID. So it's very clear relatively early on in the pandemic that there were an increasing group of patients who were displaying symptoms which became known as long COVID. And the COVID infection survey run by the ONS was demonstrating the scale of this, but looking in Open Safely, which had near live view and visibility of the GP record, very few of those people were coded as having long COVID, even after those codes came online. And therefore it's challenging to inform policy in this area. So we were able to look at this in UKLLC using participants' self-identified long COVID symptoms and found that only 4.7% of those who self-identified as having long COVID had a GP diagnosis which reflected this. And those who had that diagnosis were more likely to be middle-aged, white, and living in less deprived areas. They're also more likely to have some pre-existing healthcare conditions. And that evidence as to the patterns of long COVID contributed to NICE thinking about incentivizing GPs to code and to provide clearer instructions for coding, and had very rapid impact that way. The second example, an analyst in the National Core Study considered the fact that those who had pre-existing healthcare conditions prior to the pandemic were likely to have their care disrupted by lockdown and other concerns about viral exposure, and that disruption to their care would lead to avoidable hospitalizations and a different burden on the healthcare system. However, looking in Open Safely, that analyst used lockdown as a period of time to indicate the exposure of disruption and actually didn't find any evidence of a link between disruption and avoidable hospitalization. In fact, saw reduced amounts of avoidable hospitalization and a narrowing of inequalities. Quite a surprising finding, given that the hypothesis they started with. But then the same researcher looked to do the same question in UKLLC, where instead of using just the lockdown periods as the exposure, they used self-reported information. So those who had pre-existing healthcare saying my care was disrupted, and then they found that there was increased disruption and an increased risk of any acute and chronic ambulatory care sensitive hospital admissions. So really, both examples just drawing on the fact that the self-reported data gave a perspective which was invisible if you were just looking at the routine record itself, and that a resource which can bring together self-reported data with linked records enable the analysts to answer those questions. Right, so if that whistle-stop tour got your interest, then I'm just going to finish on a couple of slides about how you can access the UKLLC resource. So one of the things we've tried to achieve is to cut through that issue, which many of you might be familiar with, where it takes a long time to access the data you're interested in. In fact, too long to be practical in many examples. So what we've developed is a mechanism where basically we, as the resource, take the burden of the application and review process. So you, as a user, would submit an expression of interest. We'd then work with you to assess feasibility, and then work with you to advise you how to progress to develop a full application. We then manage the process of review, and each application is reviewed by us on behalf of the NHS, by public contributors to look at that public trust perspective, is this project going to deliver public good, and also by the studies whose data you want to use. Then a contract needs to be agreed, and then data provision used in an effectively automated process. We've transformed this mechanism. We're now hitting our service level agreements of expression of interest through to data provision in about 10 to 12 weeks. That's an important message. At the moment, we're centrally funded. We're free to use for our early adopters. So it's a good time to get involved if you're interested. Many of you might question, well, what's it like to work within a trusted research environment? We're really mindful that user experience is critical, and we want you to have all the information you need to be able to use these very complicated data. Now, the TRE itself, it's just a Windows machine. It's a remotely accessible Windows machine you can access from your work employer device. It's got the data science tooling, which is increasingly being used, but we're also providing the traditional analytical tools like Stata and SPSS, and we can install new software if necessary. We're developing this set of support materials, from documentation through to training materials, a help desk. And just as a flavor of this, we got a YouTube channel with bite-sized videos telling you how to do the different technical processes. We've developed startup scripts to get you your data provisioned in the software of your choice. And we're utterly committed to reusable research, where the project outcomes, such as syntax and derived variables from previous users, are catalogued at the end of their process, put in our Git repositories, and then made available to new users to make your journey and your analysis process more straightforward. So to summarize, UKLLC is a highly efficient means to access the wonderfully broad, rich, diverse data that the longitudinal studies have collected with their participant volunteers. We've established comprehensive linked records and a large pooled sample with heterogeneous characteristics. We're now refunded for the next 5 years with a remit to become a generic research database. That transition is well underway and in fact accessible for some projects. And since then, a further 35 studies have expressed an interest in joining. About 6 of those are already underway, and that might bring an additional 2 million plus participants into the database. We're developing an omics platform in Linux, because I know that community needs Linux and high throughput computing in order to do its analysis. That's underway. Working still on improved user experience, working with our early adopters and learning from their experience to make the system better, and obviously working to improve our data linkages. And I just want to say thank you as the last message to the partners, the longitudinal studies, their participants, infrastructure providers such as SERP, the public contributors who inform what we do in such a rich and meaningful way, and the wider data science community. Thank you for listening, and if you do want to know more, please come and visit us at our stand downstairs.
Thank you ever so much, Andy. And I'm sure, like many of you, when you saw that wider determinants data, are wondering why we spent £130,000 buying CPRD the other year. Anyway, but and waited a year to get it approved. But thank you very much, Andy. So I have some questions here. Please throw your questions into Slido, and we will ask as many as we can, or until Jennifer tells me I must leave. The first question, it's not that I'm accusing you, Andy, but we know that data linkage is never perfect, and the quality of the linkage has a big impact on the research that we do. So what can you do, or how can we handle sharing information and ensure the quality of that data linkage, especially when we need to preserve the subject confidentiality?
Okay, so in terms of confidentiality, the linkage is implemented by a trusted third party, which is part of the NHS. So as no one running the LLC TRE sees any identifiers. So they go from the study to the trusted third party to the different parts of the NHS and ONS. So it's kept within that bubble. We use the same record linkage algorithms as all NHS people do in terms of interactive, because they're standardized at the NHS rather than bespoke to us. We're working with linkage experts to evaluate quality and completeness. I'm going to tune the data that the studies provide to ensure fairness in that process. And I think there's people from the NHS England here at the conference who are also working to develop better metrics so we can understand the quality of the output from that linkage process in order to inform you, the analysts, about the strengths and weaknesses of the data.
Thank you ever so much. The next question, we know that often certain populations are overrepresented in their data, so you get biased selection because they have easier access to the data, abilities to be able to engage with services and therefore represented. So how do we ensure that the sample is not biased, and what are you doing to be able to highlight those changes where there may be bias?
So obviously I'm a big fan of record linkage as part of the sort of armory of data techniques in longitudinal studies. But I don't think there's any alternative to really good, rigorous field work and participant engagement and getting into different, working with community stakeholders to enthuse and build understanding amongst different population groups as to what longitudinal research is about. That's vital. In terms of the data, I think it's my responsibility to add data representing more vulnerable groups, such as, for example, children in the care system, into the TRE to ensure that their outcomes and their lived experiences is reflected in the analysis. So it's a very delicate issue, it's a very challenging issue, and we've by no means got the magic answer, but we are definitely working in that area and striving to improve equity in our findings.
Cool. Thank you very much.
They're waving a stop flag.
Stop now? No, one more, please, one more, because Lewis, whoever you are, I owe you a drink. This is a great question. What opportunities are there for local health systems to access this longitudinal data to complement the work that we are doing in pop health management and beyond?
Fantastic, great question. At the moment, we haven't got that sorted, but what I hope is the NHS are building a network of regional or subnational SDEs. I would like to think of a way in which we can communicate through federated data analysis between UK LLC as a centralised source of longitudinal data and these NHS local data science initiatives to bring the data together in a way which is acceptable to the study's participants and NHS analysts. Fantastic. A work in progress.
Thank you very much. A big HACA afternoon welcome all. Thank you. Sorry.
Thank you, Andrew.
Thank you. Thank you very much.